that's why. So today's topic is on left ventricular outflow tract gradients and intracavitary pressure gradients. And a reason I picked this topic is because it's something we see a lot of, but in terms of what we do and how we manage it and when to measure it, I was a little uncertain, and I thought maybe if I was, some others were, so I thought it would be an opportunity to learn. So Dr. Chow wanted this off the screen. Let's see. Okay, there we go. So the objectives today are to understand the difference between when there's true obstruction in the LVOT or in the left ventricular cavity, and a term we're going to describe as left cavitary obliteration. And I'll explain what that is and why it matters to differentiate the two. My hope is that by the end of this talk, you'll know when it's important to measure these gradients. And then we'll also touch a little bit on why it matters, or if it matters at all. And so the first thing I just want to ask the sonographers in the room, and hopefully you guys can hear, is do you guys have an idea of when you measure it? When are you prompted to measure an intracavitary gradient?
When we see color disturbance or a dagger shape.
Okay, right. And so, thank you, Pega. And so what Pega's kind of describing is what I corroborated with some of the staff is there's no clear kind of protocol as to when you should and shouldn't measure it, which leaves a lot of ambiguity. And so we'll kind of discuss why, or kind of clarify that. So a couple of key references here. As we'll discuss, it's often found in patients with hypertrophic cardiomyopathy, left outflow tract obstruction. So that first, okay. And so someone here is from the comments, thanks for chiming in, is saying people will measure a pressure gradient when there's a sigmoid septum or the LVOT velocity is greater than 1 meter per second. So yes, also reasons as well. Okay, and then another article in JACC, which talked about the clinical implications. And then this last article here is talking about left ventricular cavitary obliteration. What's the mechanism and why is it different from HCM? So I thought I'd start with okay, sorry, we're getting lots of answers. And I appreciate all the responses because it's nice to have like a discussion, and that's what I was hoping for. So I'm just gonna, sorry, before I get into this case, I'm just gonna summarize what some people have said. So when I asked the question, when do we measure an intracavitary gradient? To summarize, we've got when there's color disturbance, when the LVOT velocity is over 1 meter per second, sigmoid septum, hyperdynamic LV, and a hypotensive patient. So it's kind of as though you knew what was coming in this talk, because those are all things we're going to discuss. So here's a case, 78-year-old woman. She has a history of aortic sclerosis, new dizziness and murmur. The parasternal short axis shows AV sclerosis with good cusp opening. So the sonographer, I'm going to walk you from left to right, up to down. So the sonographer does the pulse or does a mitral inflow. And when they're checking the inflow as part of the routine examination, they pick up this dagger-shaped incidental finding. This is what Pega said earlier. Sometimes this is what prompts people to go hunting for a gradient. So then they go after it and they PW further. And then they switch to CW and they're trying to pick up the highest velocity signal. So that's what you see here. Then, when they found the signal, they will get the patient to Valsalva and see if there's an increase in the gradient and what it might be. The challenge with this, one, is that patients are hunting for, or sonographers are hunting for it. So it's not something they were anticipating, and now they're going, okay, do I need to do anything about it? What does it mean? And sometimes it can be a while to look for the highest gradient. You're looking. So this kind of prompts a problem. And then the question is here, is this obstruction or is it just what we call cavitary obliteration? And that's what a term I'm going to describe in this talk. And we'll come back to the case at the end. So what's your differential when you see a pressure gradient in the LV? And this is what I want everyone to kind of have in mind when they go through. So the first is LVOT tract obstruction. And so that's what we're most commonly known to see. And there's a few things that we see it in. So one is if there's mitral SAM in patients with hypertrophic cardiomyopathy, a hypercontractile LV or small underfilled cavity with a sigmoid septum, and then from a subaortic membrane. So the key here is where the gradient is. This is a gradient in the LV outflow tract. Contrast that to a cavity gradient in the, a gradient in the actual LV. And for that, that's when you need to think of a hypercontractile small or underfilled cavity. That's one option. And then the other option, which actually has more pathologic and clinical relevance, is HCM with apical aneurysm. This is an anatomic intracavitary midcavitary obstruction. So notice that I use the term obstruction for something that's more pathologic and obliteration for something that is not pathologic. And that's to kind of differentiate that one has more clinical relevance and one is more an incidental finding. And we'll go through and discuss why that's the case. Okay, so when we talk about LV cavitary obliteration, or why is there an increase in this pressure gradient in the middle of the cavity? And there's a couple of different things. So one is you have a hyperdynamic LV with a small cavity. So you can imagine the LV is contracting quite hyperdynamically. The two ends of the walls touch, and then you get an increased pressure gradient. This can be exacerbated by patients who are hypovolemic, patients who are in non-cardiogenic shock, so hypovolemic shock, and if patients are on an increased inotropic state. So if you're in the ICU and you see an intracavitary gradient and your patient fits these, you can kind of think, okay, I'm a little less worried than if the patient has, for example, a history of HCM. Now, other reasons to think about this or where this could occur is early after AVR for AS. So the patient has a hyperdynamic LV prior to aortic valve replacement. They now replace the valve. There's increased flow and they have that gradient. And then the other thing is hypertrophic cardiomyopathy, which actually is an obliteration. It's actually obstruction. Okay, so where does all this evidence come from and how do we come to this conclusion? So this was a study done by Charles Pollock, who actually originally practiced in Toronto before moving to the States. And he looked at the mechanism of intracavitary gradient and differentiation from hypertrophic cardiomyopathy. And so he was trying to look at the mechanism of the intracavitary gradient. And so it's important to note that the patients in his study didn't have HCM, they didn't have LVH, and they didn't have SAM, but they were getting these increased gradients. And so he had 87 patients, and he found the term LV cavitary obliteration in echo reports with a clear intracavitary pressure gradient. 75% of the patients were quite ill, and 71% had what he defined as a small gradient less than 36. So what you can see here is on the right, our patients from Pollock's study. And what the yellow arrow here is showing is that the velocity is actually quite small. It's not that much. It's probably a little over 1. And on the left, you contrast that with patients with HCM. This is a patient with HCM who has quite a high velocity, over 4. And so what he was trying to illustrate was that the cavitary gradients are usually small in these patients. But what he also found was that you can accentuate these gradients with Valsalva. So it behaves very similar to an HCM gradient, but one key differentiating factor is that the gradient won't be as high as you would see with HCM. Okay, now let's go shift to LV cavitary obliteration in the absence of HCM. So again, these are patients like those ICU patients, those hypovolemic patients. And it's important to recognize that not only does it not represent obstruction, and that's why I would favor using the term LV cavitary obliteration rather than obstruction. And the reason is because it's really just an epiphenomena of a small hyperdynamic cavity. It doesn't mean as much clinical significance as obstruction, and it might allow the clinician to be a little less concerned and trigger them to think of things such as the patient requires fluids or beta blockers, or this hypotension should not be treated with inotropes. It should be treated with fluids. So another study done in 1992 was quite an early study, but this looked at patients who had intracavitary flow acceleration post-aortic valve replacement. So this is another subset. It's still obliteration, but it's a unique population. And they actually use the term obstruction, but what it did found was that there is a higher post-operative mortality and morbidity with these patients. And so this comes back to why does it matter? It actually does pose increased risk post-op. And so in this study, there were 53 patients in 3 weeks post-AVR, and they were found to have a dagger-shaped high-velocity systolic flow signal indicative of abnormal intracavitary flow acceleration. And then the reason you might ask, well, why 3 weeks after post-AVR? Oftentimes they're only in the ICU for a short amount of time. And he picked this cohort because that was in the first 3 weeks, the patients could have incisional pain, which can increase sympathetic tone, increasing the hyperdynamic tonicity of the ventricle. Patients could have low hemoglobin, and then of course they could have hyperdynamic LVs post-AVR. So that was the reason for the 3 weeks follow-up. So these patients had pronounced LV hypertrophy, smaller cavities, and higher ejection fractions. Systolic anterior motion of the mitral valve did not accompany abnormal intracavitary flow acceleration in any patients. 6 of 13 patients suffered postoperative hemodynamic compromise characterized by severe hypotension despite adequate pulmonary capillary wedge pressures. And this represents a phenomena that we sometimes term suicide ventricle. And so what it is that this increased gradient results in hypotension, and if it's not properly understood that these patients need fluid, and let's say patients are given inotropes, this could result in increased mortality. And so identifying this intracavitary gradient can heighten the clinician to understand, okay, I need to be aware that this patient's fluid status is adequate, and I need to make sure that inotropes aren't the go-to. So that's where this kind of serves some clinical relevance. Another study that was done quite a far back, I'm sorry, I'm going to go to the next slide. So this was done in 1992, and it was published in Circulation, and it compared 2 groups of patients that had distinct ventricular geometry. One had pronounced hypertrophy, smaller ventricles, higher EF, and the other one had our classic intracavitary gradient, a systolic anterior motion. And what they did is they looked to see what happened to these patients. And 6 of these 13 patients suffered postoperative hemodynamic characterized by severe hypotension despite adequate pulmonary capillary wedge pressure. So when you look at this, now remember this was done in the 1990s, so this is all we had. So you have continuous wave Doppler at various phases of the hospital course. So left is taken preoperatively. The middle one is taken first day postoperatively when the patient was hypotensive. And then C is taken shortly after inotropic support was withdrawn. So what this is kind of like illustrating is that post-op after AVR, you can see that the gradient has increased. And initially they thought the patient was in shock and requiring inotropes. And when the inotropes were withdrawn, the gradient actually decreased. And so this is, again, this understanding of where the gradient is and in what clinical patient, affected outcomes because withdrawal of the inotropes reduce the gradient and hence reduce the hypertension. Okay, so what about patients with hypertrophic cardiomyopathy? When does a midcavitary obstruction matter? Because up until now, I've been telling you about what I would describe as obliteration, and it's not pathologic per se, in that, yes, there's ways we would treat it, but it's not necessarily pathologic. So when do you need to worry about a midcavitary obstruction, and when do you need to think, okay, this is something that has more clinical relevance? So this was a study done by Minami et al. And what it did is it looked at 490 hypertrophic cardiomyopathy patients with left ventricular gradients. And they described a midcavitary gradient obstruction as greater than 30 millimeters of mercury. What they discovered in this group of patients, so patients with hypertrophic cardiomyopathy, is 46 patients, or 9%, were found to have this midcavitary gradient. And so why does it matter? When they follow these patients, this midcavitary gradient was found to be an independent determinant of HCM-related death in multivariate models. So as we know, there's different predictors as to how patients do in a course of HCM. Things like wall thickness, things like history of sudden cardiac death. And so while this isn't included in the risk score for sudden cardiac death or ICD implantation, a midcavitary gradient was associated with increased morbidity and mortality. And so then, when you look at patients who have this midcavitary gradient, 28% of them had an apical aneurysm. And we know that apical aneurysms have increased, are an increased marker for sudden cardiac death in hypertrophic patients. So it's another way that these patients can be risk stratified, and it could be something that the clinician takes into account when either deciding ICD or not, or how often they follow up with serial echoes. And if this intracavitary gradient is identified, it might be useful for the clinician to actually request on the form for the sonographer to measure the intracavitary gradient. And this is why it's helpful, where this would be one incident where I would suggest or recommend that there actually be some sort of a protocol if there is an apical aneurysm, or if there is a midcavitary gradient in a patient with HCM, that the sonographers measure it. And of course, it has to be asked, but I think this is a reason why it has clinical importance. Like that. I'm sorry, my computer is dying, so I'm just gonna plug it in. I thought it was plugged in here. Sorry about that, guys. I'm gonna put this picture on to just show you. So this was a patient that went on to have an MRI, and what the stars are going to what the star indicates in section E is you can see how there is midcavitary obstruction there, and you can see you can see how you would have an increased gradient through there. And one of the key things to note why this is kind of different than just a hyperdynamic LV is that there's two separate cavities. And I have a slide that's going to show this on echo, but you have two separate cavities. You have one in the distal and one more proximal. In patients with hyperdynamic LV, for example, in a small cavity or in a hyperdynamic state, you have obstruction just distally. You don't have these two separate distinct cavities. And that's another way to differentiate the two of them. Sorry, just gonna plug in. Okay, great. So on that note, so remember, two distinct cavities. So if you're scanning the patient, how do you identify this? What if you're the first person to pick it up? What are some things that would prompt you to go, okay, I need to do this? So like was mentioned earlier by one of our sonographers, flow acceleration should prompt you to think, okay, I wonder if this patient has midcavitary obstruction. So here you can see there's flow acceleration, and when the gradient was measured, it was elevated. The other thing that this image starts to show is that there's two distinct compartments. There's one distally, and then there's one proximally. And if you look here, you can actually see where there is the midcavitary obstruction in HCM. So here, the papillary muscles, because they're hypertrophied and thick, during systole result in this obstruction. And it's a true obstruction because there are, like I said, two cavities. So I propose that when sonographers see this, they actually should take the measurement of the gradient seriously. And I'm not saying that you don't in other scenarios, but it actually has mortality and morbidity implications and could affect how the patient gets treated. So this is one indication I'm advocating that we definitely do measure the gradients. Okay, so I kind of touched on this too a little earlier, but why does it matter and why is it important? So this is another study that looked again at the importance of it. And this, again, this is actually the one I showed earlier, but this time I have some graphs that I want to show. So this is where that information came from. And so here you can see, so there's two graphs here. The blue line on the top is patients that have had a midcavitary gradient. And on the bottom are patients who, without a midcavitary gradient, and the bottom are the patients that did have a midcavitary gradient. And what we're looking at is years and on the right and risk of freedom from HCM-related death. So HCM-related death in any way, not just sudden cardiac death, although that's the most common. And what this graph illustrates is that patients with a obstruction were more likely to have a death from HCM, and they more likely were to have a combined endpoint of sudden cardiac death or potential lethal arrhythmias from that. And so that's where that data comes from. This is the graph to match it, and that's just showing it again. So if we go back to our case and we have a little bit more to go. So in this patient, I want to just bring your attention to this. And so looking back kind of after what we've discussed, so remember here, just to review, she's a patient with aortic sclerosis. Then an echo showed this midventricular gradient. Would you guys be concerned about this, or what does it make you think of? So it's one of those things where there's no the gradient isn't too high, and then the other thing I would say was that it's in a patient who, well, actually, let me show you the pictures before. Any thoughts?
Kind of looks more like apical obliteration of the cavity rather than a true mid-cavitary obstruction. So less kind of worrisome than a true HOCM picture.
Yeah, exactly. So for people that didn't hear what Chai, one of our residents, said, is that it's, and I'm just going to play it for you here, rather than true mid-cavitary obstruction, it looks like the ventricles, there's just the distal portion that's obstructed, or rather obliterated, but it's not a true obstruction of the ventricle. And then what you'll also notice here is there's chordal SAM, and there's no LVOT obstruction. And the this is you want to exclude portal SAM and exclude any type of LVOT obstruction. Because remember at the very beginning of the presentation, I said there's two types of obstructions. You can have, or location of obstruction. You can have it at the LVOT, or you can have it in the cavity. And initially, as when you're scanning as a sonographer or even as the physician, you may not know where it is. So one clue, in addition to pulsing, is to actually visually look. Where do I see that gradient might be coming from? And so here it's quite obvious that there's no SAM, there's no LVOT obstruction, but there does look to be some distal. Oh, sorry, yeah. And then here, what you see is it's all pure red, and this is another thing that can help corroborate that there's not LVOT obstruction. So I wanted to know what does the ESC or what do guidelines say about this? You know, what is there any guideline direction into when we should measure it, when we should care? And just going to skip ahead to this slide. So when I was looking through guidelines or looking through what is advised out there, there's no guideline on intracavitary gradient because it's such a minute topic and it's so specific. But this guideline gave some insight into the topic at large. And what it says, and even though it's an older guideline, I think it still applies, is it says, when a gradient is detected in the LV, it is important to systematically exclude obstruction that is unrelated to SAM, including subaortic membranes, mitral valve leaflet abnormalities, and midcavitary gradients. So what it's saying is as a systematic approach for everyone, when you see, when you notice or incidentally pick up a intracavitary or a gradient, at this point you may not know where it is. In your head, you should systematically go, okay, let me zoom in and look for any SAM. Let me, I'm going to come back to your point, but I think it's relevant. I'll just finish what I'm thinking and then I'll come back to it. So zoom in, anatomically look for SAM. Zoom in to look for any subaortic membranes, any mitral valve abnormalities, and then have a look and see is there any midcavitary obstruction, true obstruction, meaning there's two separate cavities. And then this is specifically important, this paper is saying when hypertrophic cardiomyopathy interventions are being considered. This is a hypertrophic cardiomyopathy guideline, but what I'm saying is I think we can apply these recommendations to overall looking for intercavitary gradients. There was a comment here, and I just want to incorporate it. Good to crank the color scale to see if turbulence persists if suspected gradients spot. Yeah, so that's a great idea too. And so if you're unsure, if you're going, I don't know if there's a gradient, I'm not, you can, again, as Natasha's commented, you can increase the color gradient and see, and that might help you identify. So a couple of things just to go before I summarize the two separate points. One is clinically relevant is a clinically relevant true gradient or true obstruction is relevant when it's greater than 30 millimeters at rest. It's particularly important when there's pathology. And the pathology that needs to be included, or excluded rather, is HCM, SAM, subaortic membrane, and abnormal mitral anterior leaflet papillary muscles. If you see a gradient, you should try and exclude these with images. And then if it's not, we kind of result to the fact that it's due to one of those other unique conditions. So hyperdynamic LV, small LV cavity, hypovolemia. And then we can feel more confident as the readers and as the sonographers, all of us, that it's less pathologic or there's less outcome-based effects of the patient. And so, again, just some things to look for. Here is when you look for your LVOT gradient, just making sure you show an example of looking right at the LVOT. So obviously look for it, but just demonstrate to us that you checked the LVOT, you checked that there's no significant gradient there, no SAM. And as Eamon is, and I hope you don't mind, guys, I'm just, as you guys are giving comments, I'm just including them just so everyone can see. But exactly as Eamon said, subaortic membrane usually results in a fixed obstruction, so the CW will not be dagger shaped. And what I would advocate is that even if you check it and it's not high, to just capture an image so that we know you guys have checked it, because you know, you guys do so many scans a day, you're so busy, it's hard for us to come find you and take you away. So if you check it and you document it, when we read, we go, okay, we know they looked for this, it's not LVOT, okay, it's something else. And then the other thing here is if you do see an LV intracavitary gradient, the things would be to look for HCM, so look for two distinct cavities. Or the other thing would be is looking to see if it's a normal cavity with a small, with normal size with hyperdynamic. The last take-home point is that it's not true mid-cavitary obstruction in HCM unless the mitral papillary muscle abnormality is present. And so again, you can have a hyperdynamic patient with HCM, but if it's not actually the papillary muscles that's driving that gradient, it's not pathologic. And so I kind of was the terms used interchangeably, and maybe I'm stirring the pot because I know we use gradient for everything here at our lab. So I'd be curious to hear what people think. But my thought and my understanding is that if there's no pathology related to the patient in terms of HCM, subaortic membrane, SAM, we should be shifting away and using the term obliteration. And that's just because it has less clinical significance. And for the reader, it might make somebody a little less worried if we just say it's just obliteration rather than something pathologic related to obstruction. And I think that's actually all I have. And so